In this talk, I would like to offer a collection of imaging and an overview of the treatment options for the optic pit maculopathy. So, optic pit is a spectrum of congenital cavitary anomalies of the optic disc. You can see just small optic disc coloboma or pit, and a larger appearance like in the morning glory disc anomaly where the optic nerve is involved at 360 degrees, or very large coloboma involving not only the optic nerve but the surrounding tissue like mainly the choroid. A papillorenal syndrome is also described. Today we know that it has a genetic disease and the gene PAX2 is mutated. So the incidence of optic disc anomalies is 1 over 11,000 people, so it is rare but not so rare, and every retinologist will encounter some cases. It may be bilateral. It is described bilateral in 15% of the cases. You see here the pictures of both eyes of one of my patients. He was a 10-year-old boy when I met him the first time, with a huge coloboma of the optic nerve, choroid, and retina, with a visual acuity of 0.1 in both eyes, where he could fixate. So what about the pathogenesis? The disease was first described by Whitty in 1882 as a herniation of dysplastic retina into a collagen-rich excavation that extends into the subarachnoid space through a defect in the lamina cribrosa. Today we have 3D OCT imaging. We can see the connections among vitreous cavities, subretinal and intraretinal space, and the perineural space. This connection has been reported in literature, as you can see in the citations down here. And basically it tells us that there is a passage of fluid from one cavity to the other, and that can explain the advent of subretinal fluid and intraretinal fluid through the connection into the optic nerve itself, as you can see here. So look at this video. You will see at the end of the video a small hole indicating the passage like a tube into the optic nerve, connecting the perineural space to the retina and the vitreous cavity. Not every optic coloboma has a detachment. As you can see here in this very long scan, this boy has optic disc coloboma but no retinal detachment. In this slide you see different presentations of retinal detachment. The extent of the detachment is very different, from small area in the macula to the whole posterior pole, or it might have a gravitational appearance. In fact, it has to be differentiated from other types of serous detachment. It may resemble a central serous chorioretinopathy as well, but you will find the pit in the coloboma. So this patient was sent to me in 2008 with the diagnosis of central serous chorioretinopathy, and in fact, if you look at the fluorescein angiography, you can see the gross appearance of the RPE, which is completely remodeled. In the color picture, you see areas of hypopigmentation of the RPE. So again, yes, it might resemble a central serous chorioretinopathy, but then you observe the pit in the temporal side of the optic nerve. The European Vitreoretina Society, EVRS, conducted a review in 2014, collecting data on optic pit from 200 eyes, and among them 189 were accepted for analysis, submitted by 63 retina specialists around the world from 21 countries. Let's see which were the baseline characteristics of these patients. As far as gender and age, we know, and it was confirmed, that there is no predilection of gender. It's equally distributed between male and female, and the age of presentation is adult age, but young, 33 years of age. The lens status was, as expected, phakic for most of the patient. And the first treatment option that was referred from the colleagues had this distribution, as you can see in the graph. Vitrectomy plus laser plus tamponade in almost 40% of the cases. Observation, so some of these patients, 20%, were not treated. And 18%, almost 20%, received vitrectomy with tamponade without laser. Some of them only tamponade, so just an injection of gas, some of them just laser, or the combination of the two. Some, but very few, only vitrectomy, and 1.1% received a combination of different treatment. The graph shows that different treatments, surgical techniques, had an almost equal effect in reabsorbing the subretinal fluid. What did they have in common? They had in common the use of a tamponade. So even injection plus laser without vitrectomy reached a similar result to vitrectomy in this review. The type of tamponade was either air or different type of gas in a small part silicone oil, as you can see. The visual acuity improved. So this graph shows that it's worth operating because there is a significant visual gain when you operate the patient. 16%, although, received a second treatment. It means that some of them had a persistence of subretinal fluid and some of them had a relapse. So the main conclusion from the EVRS optic pit study were that treatment is better than observation, that vitrectomy laser plus tamponade or vitrectomy tamponade or laser plus tamponade had equal value, that visual acuity improved and kept improving with time when the anatomical success was reached, and that a second treatment improved the anatomical result and was necessary in 16% of the cases, and that the complications were reported mainly for vitrectomy. So, as always, many good treatment proposal means no good treatment. In literature, you can find bed rest with ocular patching, laser alone, macular buckling, pneumatic displacement with or without laser, and more recently vitrectomy with different optional, just with the tamponade, with drainage of subretinal fluid, with laser around the pit or around the optic nerve, different types of ILM peeling, and different sorts of stuffing the pit. So what do we use to stuff the pit? The ILM, fibrin sealant, different types of glue, and you will see how many tools are actually used, as the fantasy is free to go. Anyhow, vitrectomy can lead to satisfactory results. Look at this case, a case of a boy, 15 years old, 0.1 vision with a detachment that involves the whole posterior pole. After vitrectomy and ILM peeled over the nasal side of the macula and stuffed into the pit, you see a progressive improvement in vision and anatomy. And this is 1 year after surgery. It looks beautiful. However, it's true that there is a high rate of relapses. In this case, you see the detachment that recurs a few years after the first injection of gas during vitrectomy with ILM peeling. So the same technique. It was perfect for 2 years, and then he had a relapse. So when he had a relapse, the intraretinal fluid and subretinal fluid was not so much. In this case, I decided to apply micropulse laser before going back to surgery, and indeed I obtained a good reabsorption of all the fluid. So we should actually consider micropulse as one more option that we have today to reabsorb a small amount of fluid either intra or subretinally. So why does the fluid come and go and then come again? Well, the dynamic of the intracranial pressure could explain the opening and closing of the pit. So basically there is a valve in the pit that allows the fluid to go, and maybe only differences in the intracranial pressure can't explain the reabsorption of the fluid that occurs sometimes and the reappearance. So at this point, what is the key step for successful and long-lasting surgery? Well, it seems that in fact to seal the pit is the key of success. So stuffing the pit is very important. And I would say that using tissue that is already in the eye on the retina, like the internal limiting membrane, seems to be the best option. But if you have to operate patients that already have been operated, they have recurrences, or you cannot obtain a good ILM flap, these are the possible alternatives that actually have been described. This is a video offered by Professor Eckert. He used the ILM with the air tamponade. And then you see that he's doing the OCT just 1 day after. It looks beautiful. 6 days post-op, you still see the bubble, 2 weeks. But then look, some bubbles inside the posterior pole under the retina. So definitely some air is coming back, and the pit is not sealed. So what did Professor Eckert do? He used a small fragment of sclera to stuff and seal the pit. Another colleague, Dr. Hussein Akan, sent me this video to show one more option. He had a macular detachment with the macular hole secondary to optic pit. And so he used a combination of techniques. He used, as you can see here, a puntum plug. He plugged the pit with a puntum plug. The puntum plug actually is fitting perfectly the pit. It's pushed inside with forceps. There you go. You can see the puntum plug in the pit. And then, since he had the macular hole, he treated the macular hole with a graft of amniotic membrane over the retina. And the case was actually very successful. He could seal the pit and take care of the macular hole as well. So what if it's not just a pit, but a huge coloboma of the optic nerve and the choroid? And what if there is a macular hole inside the pit? This is the boy that I was showing in the first slides. 7-year-old with bilateral coloboma of the optic nerve and the choroid. I followed the boy for a while and then he developed detachment in the left eye. And in the video you see my decision on management. So I was very strong in the idea of avoiding silicone oil because it is described that silicone oil can go through the pit to the brain. And I didn't want to take any chance with this young boy. So you can see I'm exploring the pit, finding the macular hole right there. You see the yellow macula inside the coloboma. So how to take care of that? Because we cannot use laser, there is no pigmentation, the macula is in a very bad area. So how to attach? I decided to use a macular buckle and push the sclera from behind. I chose a size that could fit the small eye. And then I completed the surgery with the peripheral vitrectomy. I left the lens in place and then I exchanged with air through the hole. And you can see the retina reattached and it remained reattached for at least 4 years. This has been the follow-up. So this is my personal case series of optic coloboma collected between 2008 2017. I have some more now. And as you can see, I used to approach this patient with optic pit with laser first and injection of air, and then vitrectomy only for failure. So in this table you can see the result of the injections and laser in the first row, which was successful in 4 cases over 7, and but they had a relapse, but even years later, as you can see. So since we are speaking about young boys, I think this is a good option to start. And you can apply vitrectomy as a second option only in case of relapse or persistence of the fluid. And then after vitrectomy, you can see a higher chance of success even in long follow-up. So in summary, I think that it is reasonable with start with gas injection and laser just around the pit. It's reasonable to wait at least 6 months because it takes time to reabsorb the fluid. If there is definitely no change or recurrence, the right approach is vitrectomy, stuffing the pit with the ILM if you can. And if you don't have the ILM, you have to find something else. And nowadays it seems that the amniotic membrane is a good option to close the macular hole if it's there, and also the pit. Remember to give it a try to micropulse laser in case of small blebs or collection of intraretinal fluid. Thank you.